Surgical, metabolism, and electrolytes. This is a high-yield, rapid review, so we're skipping the preamble and jumping straight into the clinical drill right now. Let's go.
Question 1. A patient who is dehydrated with anuria is most likely to have which of the following underlying abnormalities? Is it A, hyperkalemia, B, hypokalemia, C, hyponatremia, D, hypocalcemia, or E, hypoglycemia?
If you guessed A, hyperkalemia, you nailed it. Here's exactly why this happens. Severe dehydration just tanks your intravascular volume. That causes a profound drop in renal blood flow, which we clinically call prerenal azotemia. If you don't step in and correct this quickly, it progresses straight to acute renal injury accompanied by anuria, literally a complete lack of urine production. Now, the absolutely crucial point here is that the kidneys are your primary mechanism for potassium elimination. So an anuric patient, they physically cannot excrete it. That leads to a rapid systemic accumulation of the ion and eventually life-threatening hyperkalemia. And here's a quick clinical pearl for the wards. Acute oliguric or anuric renal failure characteristically shows up with hyperkalemia, fluid volume overload, and a progressive high anion gap metabolic acidosis.
All right, keep the momentum going. Which of the following is an important cause of hyperkalemia? A, renal failure. B, hypertrophic pyloric stenosis. C, secreting adrenal tumors. D, hyperaldosteronism. Or E, diarrhea.
The answer is A, renal failure. Honestly, it's the single most important clinical cause of hyperkalemia you'll see. The moment glomerular filtration drops, the body completely loses its primary mechanism for potassium homeostasis. But what's really interesting here is how we can contrast this with the other options. Those actually form our classic hypokalemic blueprints. For instance, hypertrophic pyloric stenosis, that causes persistent vomiting of acidic stomach contents driving hypokalemia. Adrenal tumors that secrete excess aldosterone literally force your kidneys to waste potassium in exchange for sodium, and severe diarrhea washes away massive amounts of fluid and potassium right in the stool, giving you hypokalemia paired with a normal anion gap metabolic acidosis.
Let's keep the drill going. Which of the following should be given in reduced amounts in patients of renal failure? A, sodium. B, potassium. C, calcium. D, bicarbonates. Or E, none of the above.
We're going with B, potassium. Surgical patients in advanced acute or chronic renal failure need highly specialized nutrition just to prevent electrolyte toxicities. This perfectly illustrates the formulation mechanics behind specialized renal formulas. These enteral and parenteral blends are strictly engineered to pack a high-calorie density into minimal fluid, all while significantly reducing concentrations of potassium, phosphorus, and magnesium. And to minimize urea generation, they prioritize essential amino acids and feature a super-concentrated non-protein calorie to nitrogen ratio.
Okay, let's flip the imbalance entirely. Which of the following is the cause of hypokalemia? A, blood transfusion. B, rhabdomyolysis. C, metabolic acidosis. D, diarrhea. Or E, hyperglycemia.
The answer here is D, diarrhea. You see, gastrointestinal secretions below the stomach are highly alkaline and just packed with potassium. So naturally, severe diarrhea causes a rapid loss of water, sodium, potassium, and bicarbonate. Now contrast that with its hyperkalemic counterparts. Massive or rapid blood transfusions actually trigger hyperkalemia because those stored red blood cells start leaking intracellular potassium over time. Similarly, rhabdomyolysis from severe crush injuries bursts muscle cell membranes wide open, dumping massive stores of intracellular potassium straight into the bloodstream.
Time to test your clinical signs. Which of the following is associated with hypokalemia? A, tall tented T waves on ECG. B, ileus. C, short QT interval. D, sine waves. Or E, central pontine myelinosis.
If you said B, ileus, you're absolutely right. Potassium is absolutely vital for maintaining the resting membrane potential of excitable tissues. When those potassium levels fall, cell membranes actually become hyperpolarized and much less responsive. In the GI tract, this blunts smooth muscle contractility, giving you a functional paralytic ileus. Now let's urgently drill those ECG signatures. Hypokalemia throws up a prominent U wave, an inverted T wave, and a really deceptive prolongation of the QU or QT interval. Don't let tall tented T waves or sine waves fool you. Those are pathonomic for severe hyperkalemia, definitely not hypokalemia.
Moving on to biophysics. Which of the following is true regarding normal water balance in the body? A, protein catabolism excreted by 300 ml urine.
B. Lungs' primary source of loss. C. Decrease in temp decreases water loss. D. Normal insensible loss is 600 to 900 ml per day. Or E. Excessive catabolism causes massive water loss. Option D is the correct statement here. The normal daily insensible water loss sits right at 600 to 900 milliliters per day. A healthy adult loses this water continuously without even realizing it's happening. Roughly 75% of this is just passive diffusion through the skin, and the remaining 25% is exhaled humidified air straight from the lungs. And here is an absolutely critical pearl to lock in. To clear the toxic waste products of daily protein metabolism, your kidneys must excrete an obligatory minimum urine volume of at least 400 milliliters per day. Anything below that threshold, you're essentially guaranteeing toxin accumulation.
Let's pivot to a clinical calculation. What is the total caloric requirement of a 40-year-old male patient weighing 70 kilograms post-emergency exploratory laparotomy for blunt trauma? Is it A, 500 cals per day, B, 1,000, C, 1,500, D, 2,000, or E, 2,800 cals per day?
The target here is E, 2,800 kcal per day. Let's actually walk through the math on this one. Step 1 is calculating basal energy expenditure using a standard 25 kilocalories per kilogram per day. For a 70-kilo male, that's 1,750 kilocalories. Step 2 applies the activity factor. Since our guy is bedbound post-laparotomy, we multiply by 1.2. Step 3 is the injury factor. For an emergency major abdominal operation from blunt trauma, the multiplier is 1.35. Multiply all those together, 1,750 times 1.2 times 1.35, and you hit right on our target of roughly 2,800 kcals per day. And remember, protein requirements scale dynamically right alongside these stressors, jumping from a baseline of 0.8 grams per kilogram all the way up to 2.0 in severe cases.
Next up, which is correct regarding daily maintenance fluid in the surgical patient? We've got 5 different tier ratios here. Is it A, B, C, D, or E? Look closely at the split for the first 10, second 10, and subsequent kilograms.
Option B is the winner. The standard weight-based method for daily maintenance fluids is a strict 3-tiered scale. You do 100 milliliters per kilo for the first 10 kilograms, then 50 milliliters per kilo for the second 10 kilograms, and finally 20 milliliters per kilo for each subsequent kilogram. This is great because it translates perfectly into the famous hourly 4-2-1 rule. 4 milliliters per kilo per hour for the first 10, 2 milliliters for the second 10, and 1 milliliter per hour for every single kilo after that.
Let's talk substrate selection. Which of the following fluids should be given postoperatively as maintenance fluid? A. Ringer lactate. B. 0.9% normal saline. C. Dextrosaline. D. 5% DW. Or E. 5% DW with lactated ringer.
The clear choice here is E, 5% DW in water mixed with lactated ringer. But why do the others fail on their own? Well, pure 5% DW has absolutely zero electrolytes. Give that alone for maintenance and you're essentially asking for severe dilutional hyponatremia. On the flip side, pure normal saline or pure Ringer's lactate deliver the vital electrolytes, but they contain zero glucose. That means they completely fail to suppress starvation-induced muscle catabolism. By combining a carbohydrate substrate with an isotonic crystalloid, you're providing balanced electrolytes while actively minimizing starvation ketosis. It's the best of both worlds.
All right, time to apply that formula from earlier. Miscalculating this on the wards can have really severe consequences, so getting it right is non-negotiable. What amount of daily maintenance fluid will be required for a 60-kilogram man? A. 2,000 mLs, B. 2,300 mLs, C. 3,000 mLs, D. 3,500 mLs, or E. None of the above.
If you calculated B, 2,300 milliliters, you're spot on. Let's trace the steps. Step 1. The first 10 kilograms gets 100 milliliters each, so that's 1,000 milliliters. Step 2. The second 10 kilograms gets 50 milliliters each, adding 500 milliliters. Step 3. For his remaining 40 kilograms, we multiply by 20 milliliters, which gives us 800 milliliters. So 1,000 plus 500 plus 800 equals a total of 2,300 milliliters. And hey, as a quick clinician's rule of thumb to cross-check yourself, you can just estimate 30 to 40 milliliters per kilo per day. For a 60-kilogram patient, that's 1,800 to 2,400 milliliters, perfectly confirming our exact 2,300 milliliter calculation.
Moving from fluids back to energy. A normal person without any comorbidities would get how many kilocalories per day? A. 15 to 20, B. 20 to 30, C. 30 to 40, or D. 35 to 50 cals per day.
The right answer is B. A stable adult needs a baseline of 20 to 30 kilocalories per kilogram per day just to preserve cellular integrity. But let's look at how wildly this shifts under stress. If a patient is undergoing prolonged, uncomplicated fasting, their adaptive starvation profile actually drops their basal energy expenditure down to 15 to 20 kilocalories just to conserve energy. But throw in severe trauma or advanced sepsis, and their hypermetabolic profile spikes drastically, pushing those requirements all the way up to 40 kilocalories per kilo per day.
Let's tackle the final scenario in this drill. Basal or resting metabolic rate is increased from its baseline value in uncomplicated surgery up to what percentage? A. 10%, B. 20%, C. 30%, D. 40%, or E. 50%.
Hit A, 10% hard. An uncomplicated elective operation really only causes a mild metabolic disturbance, increasing the basal metabolic rate by just 10%. But from there, the escalation matrix is incredibly aggressive. Standard trauma pushes the BMR up 15 to 25%. Multiple complex fractures, that pushes it to 30%. Major intra-abdominal peritonitis or sepsis rockets it to 50%. And at the absolute extreme, severe thermal body burns covering more than 40% of the body's surface area trigger a massive 100 to 200% surge in basal metabolic rate. So if a routine surgery alters metabolism by just 10%, consider how aggressively you're going to need to adapt your nutritional and fluid strategies the next time a severe trauma patient rolls through your doors. Will you be ready?